Thomas Ebert. He will speak now about the practical use of these novel therapies that we're discussing today. Thomas Ebert is an endocrinologist, diabetologist, and clinician scientist at the Medical Department 3 for Endocrinology at the University of Leipzig in Germany. Thomas is interested in microvascular complications in obesity, insulin resistance, and diabetes. He also spent 3 years here in Stockholm with Dr. Stenwinkel and his team, and also spent time as a visiting researcher at Vanderbilt University in the US. He has more than 100 publications, and we're very much looking forward to hearing from you.
So thank you, Jochen, for the kind introduction. And most importantly, thank you for the RRI and the organizing committee for setting up this kind of meeting, covering these important aspects in metabolic therapies nowadays. So as I have already mentioned, I'm not a nephrologist, but just a poor diabetologist and endocrinologist. And as a poor diabetologist, these are my potential conflict of interest. So you see, mostly related to companies from the diabetes field. And the aim of the talk today is to provide some practical aspect on the usage of these novel modern anti-CKD treatment options we have now. And the question is, can I present better subgroup analysis compared to Natalie's talk in the morning? No, I can't. Can I provide you with some more interesting data on incretin, twin cretins, or triple cretins compared to HIDO? Of course, no. So that's why I just really went into practical aspects and asked myself 5 different questions, which I try to answer in the next few minutes and discuss these questions afterwards with you all. So my first question is when to start all of these modern anti-CKD treatment options. Second question, is there a legacy effect of these kind of treatment options? And we have heard, I think it was at the Slido questions, a question directly related to this point. Number 3, do we have specific adverse events in all of these modern anti-CKD treatment options, specifically increased in individuals with CKD? Also, this came up in the first session. And then, is it now enough when we have incretins and SGLT2 inhibitors? Do we need to take care on any other aspects or just do the fire and forget therapy? And finally, the question that always comes up in this kind of symposium, what about individuals with type 1 diabetes? So, starting with the first question, when to use and when to start with GLP-1 receptor agonists, when to start with SGLT2 inhibitors. And of course, we can extract all of these information from the outcome trials. So for CKD endpoints, and the talk is just focusing on these endpoints today, we can of course extract the information from the baseline characteristics of the Credence trial, the DAPA-CKD, the EMPA-KIDNEY, and the FLOW trial. And then we can, of course, extrapolate the eGFR slopes from the placebo group on the left to the treatment intervention group on the right, and then we can calculate the difference in years for a distinct endpoint, in this case, an eGFR lower than 10. However, when we talk to our patients in a GP practice, when we are on a geriatric ward, we might ask other questions. So we might ask the question, what about the 40-year-old person, and not the average credence patient? What about a 90-year-old person, and what about longer treatment periods compared to the study treatment durations? And Clearly, we have seen the subgroup analysis and the comparison with regards to age this morning. I have added the DAPA-CKD subgroup analysis for age. There is no really interaction of age on the renal endpoints in DAPA-CKD trials, and as we have learned today, also in the MPAR kidney trials. However, you can appreciate that this is not an usual normal distribution curve. So the question remains, what about a patient in the age of 50 or in the age of 70 or 80? And we cannot really extract these data from the studies with the renal endpoints we have. But we can at least do some models trying to extrapolate these information. And here is one example study published some weeks ago from the group of Hiddo. They performed a Markov model extrapolating kidney replacement therapy initiation in different age groups, in different eGFR baseline groups compared to dapagliflozin and placebo. So there is some part of a response to this question from these models, but of course with the usual limitations of, for example, Markov models. As a next question, I would like to ask whether there is a legacy effect for these novel anti-CKD treatment options. So once again, this goes into the same direction. When should I start these novel treatment options? And just to remind you on the legacy effect, these effects have been described in the 90s of the last centuries, starting with the DCCT, but especially the UK PDS trial. And what they did in the UK PDS trial, they randomized patients with type 2 diabetes in an intensively treated group. Intensively meant sulfonylureas and insulin or metformin versus a conventional treatment group. So this is the diet standard care group. And of course, these different interventions produced a differential HbA1c. And then the UK PDS study stopped around 1998. And then the HbA1c curves were similar between both groups because UK PDS has clearly shown that it makes sense to lower the HbA1c. However, in the long-term follow-up, these glycemic differences between both groups translate into a microvascular advantage up to 20 years after the interventions between both groups. So there is some kind of metabolic memory. And of course, you can clearly say, well, these data are quite old. Isn't there anything new? Isn't there any other study confirming these results? There are several data confirming this legacy effect, especially with microvascular complications. So here on the left side, you can see data from a Kaiser Permanente register from the US, and compared to the reference group, this is the reference with one of an HbA1c lower than 6.5%, we can clearly see that if we have a higher HbA1c in the first 12 months of diagnosis of a type 2 diabetes, then we have an increased risk for microvascular endpoints. And if we have the higher HbA1c for up to 2 years or 24 months, then we have an even increased microvascular risk. So there are some data on long-term effects of early glycemic control. And we have data for type 1 diabetes study, this DCCT, but especially for type 2 diabetes individuals. The question is now, do we have a metabolic memory due to the treatment of these novel compounds, which we heard in the morning? And so far, we don't have the data. However, we have some cohorts, and this is an example recently published from an Italian group comprising about 250,000 individuals from all across Italy. And they evaluated a legacy effect of the compound SGLT2 inhibitor. And what they studied was compared to the reference group with an HbA1c lower than 7% in this study, whether a higher HbA1c resulted into more macrovascular events. And yes, of course, if you have for the first 12 months of your diabetes career an HbA1c higher than, for example, 8%, then you have a higher hazard ratio for cardiovascular endpoints. And interestingly, if you are treated in the first 12 months or in the first 24 months with an SGLT2 inhibitor, these are the black circles, then this effect is gone. So the SGLT2 inhibitor prevents this metabolic memory effect by the treatment of this compound. And unfortunately, these are only the data for macrovascular complications. However, Paola Fioretto is on the author list, and I really hope that soon there will be some microvascular complications on this. In the morning, we have also heard many information on the incretin-based therapies. And the same question is, of course, valid for all of these novel compounds on the incretin treatment approach. And I truly believe that it's possible that these novel agents produce a legacy effect for renal endpoints. And I believe this because we are nowadays not only treat hyperglycemia as an anti-diabetic intervention, but with these drugs we provide a benefit on many other metabolic endpoints contributing to microvascular complications such as hypertension, such as excess body weight, etc. So we don't have the data for these kind of analysis yet, but in principle, this is very likely that it could result in a legacy effect also for these incretins. Then, as the third question, which has also been discussed in the first Q&A session, are there more adverse events? What is the safety of these novel anti-CKD treatment options in patients with CKD? And just to mention some aspects, we are currently always asked from the GPs, what about GI side effects? What about electrolytes? And there are some colleagues, especially in geriatric departments, who always stop SGLT2 inhibitors in patients older than 80, which is, from my perspective, not understandable. But we need to discuss especially these side effects with our colleagues from the GP and the geriatrics. And of course, when comparing adverse effects in patients with CKD, there is not a lot of data. So many data is derived from network meta-analysis or healthcare databases. And I have just brought you a first example on the overall adverse event rates, and here especially serious adverse events. And when comparing SGLT2 inhibitors and GLP-1 agonists versus placebo, we see that especially SGLT2 inhibitors produce less frequently serious adverse events compared with the placebo group. The other effects are not significant. So at least what we can say, there's no increased serious adverse event rates in individuals with an eGFR lower than 45, and for SGLT2 inhibitors compared to placebo, we see it less frequently as AEs. As I have mentioned already, many GPs are a bit frightened when we play with SGLT2 inhibitors, especially in the elderly population. They might produce some electrolyte disorders. And what about potassium in this vulnerable cohort? And I'm sure so you all know these data. But when it comes to hyperkalemia and an increased potassium concentrations, these are quite new data some weeks ago stating that for SGLT2 inhibitors on the left side, for GLP-1 agonists in the middle panel, we have a lower risk for hyperkalemia compared to other anti-diabetic treatments. And when we compare SGLT2 inhibitors versus GLP-1 agonists, we further see an improved or a less frequency of hyperkalemia rates in SGLT2 treated individuals, which means that hyperkalemia is not cannot be raised as a concern from our GP colleagues. So hyperkalemia is especially less frequently observed in SGLT2 users. What about the gastrointestinal side effects? And of course, this is not important for SGLT2 inhibitors. This is important especially for the incretin-based therapies. And when we look for meta-analysis covering these aspects in individuals with chronic kidney disease, there's only very, very limited data clearly depicting nausea, vomiting, and all the other GI symptoms after an incretin-based treatment approach. In fact, there are only 2 studies, and I would like to focus especially on one of them. And I would like to focus on one of them because this study was published by Thomas Ebert, who was my mentor during my postdoc period here at the Karolinska Institute. And in his time at Copenhagen University, prior to moving to Novo, he did this very nice study investigating liraglutide treatment option, which we usually do not do anymore, but still the treatment option with improved cardiovascular outcome. And he could quite nicely show that there is an increased risk for nausea and vomiting among patients with end-stage kidney disease compared to control subjects. And one line is 1 patient, so this is only a very small study. And what could clearly be seen is that most of these adverse gastrointestinal events occur during the dose escalation. And when we see these kind of patterns, they always remind me on the novel incretin data, which have been published during the last 24 months. And when we just took tirzepatide, which Hiddo introduced this morning, and show the similar data from nausea rates for tirzepatide, they look quite the same. Of course, the number of patients is much larger, but we see gastrointestinal side effects, especially in the dose escalation treatment period. So for tirzepatide, this dose escalation in the 50 milligram group is usually stopped in week 20. Then we are in the final dosage. And then we see that there's quite a low rate of gastrointestinal side effects, which is stable. And also placebo patients develop some kind of gastrointestinal side effects. So the pattern looks more or less the same, although the number is a bit higher in individuals with CKD. Last but not least, malnutrition is a highly relevant aspect in patients with advanced CKD and end-stage kidney disease. And this figure you have already seen from Peter's presentation, and many authors from this nice review are within us, within our group today. So clearly, inflammation and inflammaging produces an malnourished or a malnutrition-prone phenotype. And then there are always colleagues who are frightened. And when we use more these GLP-1 agonists, then this could be, and so on and so on. And we have to clearly admit that for all of these novel incretin-based therapies, patients with a low BMI, usually lower than 23 kilogram per square meters, were excluded, for example, for the tirzepatide studies. So we don't have data on these patient groups with a low BMI. However, we are able, once again, for tirzepatide, we are able to individually titrate the dose of tirzepatide. And we usually do not necessarily go to the maximum 50 milligram dosage in all individuals. So we can clearly also define a lower dose as the target dose for these kind of individuals. Okay, so question number 4. Now we have all these data we have seen in the morning session, and these data is really brilliant. So do we need anything else besides GLP-1 agonists, SGLT2 inhibitors, RAS inhibitors, of course, and MRAs? So do we really need to take care on the hyperglycemia anymore, or is this irrelevant? And do we still need insulin for the treatment of diabetic kidney disease? Well, of course, I have some conflicts of interest, being a diabetologist myself. So I would definitely say that hyperglycemia needs to be controlled and needs to be addressed, despite all of these novel and very, very impressive data. And some reasons why I think that we still need insulin and other anti-diabetic agents, irrespective of these FAB4, is listed here. So, of course, usually patients with chronic kidney disease due to diabetes have a long diabetes duration, and a long diabetes duration usually associates with progressive beta cell failure. Then the glucose-lowering efficacy of SGLT2 inhibitors are usually lost in individuals with chronic kidney disease. We have the problem that several oral anti-diabetic treatment options are not possible in individuals with impaired renal function. And it's strange, but there is not only type 2 diabetes. Throughout the meeting, we were mainly focusing on type 2 diabetes, but fortunately, there's also some other types of diabetes, type 1, and other specific types of diabetes. And we still need to take care of those individuals as well. So a very polite and quiet yes, we still need insulin and other agents for managing individuals with diabetes and CKD. But how should we manage them, for example, with insulin? Should we aim for a tight control? Should we aim for a non-tight or I don't care control? And quite often, this Cochrane review is cited comparing an HbA1c below 7% versus HbA1c above 7%, and stating, well, an intensive anti-hyperglycemic therapy does not translate into an improvement of primary renal endpoints. And in this review, or in this Cochrane review, about 11 RCTs have been included. And the data is, of course, from several patients. However, most of these studies focusing on type 2 diabetes, and most of these studies included here are from 2000 or earlier. And when we do some subgroup analysis from these 11 RCTs included in this review, then we see some advantages in albuminuria progression with tight glycemic control. However, we need to acknowledge that there's a very, very low event rate in these 5 studies. And they mix between type 1 cohorts and type 2 diabetes cohorts. So I think one needs to really carefully have a look on this Cochrane review. So from my perspective, it is still highly relevant to address the glycemia and the glycemic status in individuals with advanced chronic kidney disease. And I will just provide you with an example of an analysis where we just did a very simple test and intervention to evaluate insulin treatment options in patients with hemodialysis. And here we had a possibility to access a very large data set from FMC, the so-called RO2 cohort. It's a pan-European cohort. And we extracted all individuals with type 2 diabetes, which was in this case around 1,400. And we did, in a first step, a very, very simple analysis. We just compared insulin analog treatment versus human insulin treatment. And with these very, very easy analysis, we saw that insulin analogs here in green were associated with a reduced mortality compared to human insulin users. And of course, we adjusted this for several potential confounders and asked ourselves, how can this be true? So we analyzed hypoglycemic rates. These were not different between both insulin treatment groups on the left panel, on the right panel, and we also evaluated the HbA1c between both insulin treatment groups, and this was also not significantly different. So there's a lot to do in these vulnerable individuals, and this is just an example what we still need to investigate. Last but not least, I would like to discuss some very basic points also on individuals with type 1 diabetes. Type 1 diabetes has the problem that it has quite a high prevalence of cardiovascular and renal diseases, which are then the predominant cause for premature mortality in individuals with type 1 diabetes. And when you have a look on all hemodialysis patients with diabetes, then type 1 diabetes is clearly overrepresented compared to the overall prevalence, type 1 versus type 2 diabetes. Furthermore, and these data are quite recently published from the US, we see that individuals with type 1 diabetes migrate to a type 2 diabetes phenotype. So the prevalence of obesity and associated metabolic complications is comparable to a non-diabetic US control group. So the cliché that a type 1 diabetes individual is always lean, is always young, is definitely not true anymore. So therefore, one could definitely ask the question, would these treatment options also beneficial for individuals with type 1 diabetes? And I think it was Peter Rossing who brought this up with one slide. Of course, this would definitely make sense. And the only large paper which I found was from end of last year in Diabetologia, published using data from the worldwide TreeNetX platform, where several thousands of type 1 diabetic individuals are having their data online. And then they extracted all those type 1 diabetic individuals who also used GLP-1 agonists and SGLT2 inhibitors. And then they did a propensity score matching between both groups, having around 1,800 individuals for this comparison. And then they analyzed the renal endpoints and other micro and macrovascular endpoints on a 5-year base. And what you can see here is that there was no significant differences between GLP-1 receptor agonist users with type 1 diabetes and SGLT2 inhibitor users with type 1 diabetes, except for the red marked components, which is hospitalization, heart failure. I'm not an expert in this, but especially we saw an advantage for SGLT2 inhibitors for development of chronic kidney disease. This is quite interesting. This makes sense. We know that SGLT2 inhibitors were approved in Europe for the treatment of type 1 diabetes. There was one compound. However, this license was withdrawn from the company, but not for safety issues. That's quite important. And of course, these data comes with some costs. So we have a higher rate of diabetic ketoacidosis and urinary tract infection in this retrospective cohort. And most of these individuals were without any chronic kidney disease. And when they analyzed a subset of this 1,800 subjects, comprising only 50 users for the GLP-1 group and 50 SGLT2 users with pre-existing CKD, they still saw that SGLT2 inhibitor were associated with a more preserved eGFR compared to the GLP-1 receptor agonists. With this, I would like to close with these 5 takeaway messages. So there is clearly an age-independent effect of these modern anti-CKD treatment options. We have some modeling derived data for estimating the risk for also 40 to 50 and 80-year-old individuals. However, we don't have RCT data, as we have discussed this morning. There might be a legacy effect of these modern anti-CKD therapies for macrovascular complications, but we need more data for microvascular effects. The side effects of these novel agents are, I would say, within the expected range, slightly increased for GI side effects of incretins, but sometimes even lower for distinct adverse events. Hyperglycemia, from my perspective, still needs to be taken care. And for type 1 diabetes, CKD progression and CKD prevention is, in general, improved by SGLT2 inhibitor compared to GLP-1 agonists. However, none of them is approved for the use in type 1 diabetes, and this must be on an individual case-by-case decision. And with this, I would like to close. Thank you for your attention.